Well, what do we hope to accomplish today? When I took on the presidency of the NLMA last June, I mentioned in my inaugural speech that I wanted to do something to raise the profile of seniors in this province. I had grandiose ideas of a traveling roadshow to hear from people around the province and perhaps having a Seniors Pride Day. Well, the government did that consultation tour in the fall, and the NLMA sort of got involved in contract negotiations with government. So after Christmas, I again brought up the desire to highlight the issue, and a small group of us have been working toward this day. We decided to focus on the medical model of care which will be needed, care provided by the medical, nursing, and social work professions in hospitals, nursing homes, and the community. We have invited you, frontline doctors, nurses, and social workers, to a think tank. That's what today is. I know many other groups were not invited. Seniors resource centers, homemaking agencies, advocacy groups such as the Alzheimer's Society are all very important but are not present here today. We have purposely kept our focus narrow while acknowledging it is hard to separate the medical model from these social structures. These will also have to change to solve many of the anticipated issues seniors will face. I want you to take a holistic approach today. Use your professional work experience, but also your experiences as a family member, and also your anticipated needs as a consumer in the next 10 or 20 years. Some of us are much closer to being a consumer of seniors' care than others. All of these different perspectives can influence your opinions. You've been drawn from many facets of health care, but are not here exclusively to represent just your piece of the puzzle. In the letter I wrote you, I asked that the focus be on 2025, just 15 years away. I want this meeting to be productive, with a list of things we think we can accomplish in that time span. I also asked you to consider what changes you want to see. These may be big or small. During the day, we will be collecting these ideas. And thank you to those who have thought deeply about the changes they would envision. The NLMA will write a report on what we say and debate here today. This will be accessible on our website for comments from the public and other healthcare providers. We will also discuss our findings with the provincial government. Where we go from here is undecided, but hopefully we'll have more clarity by the end of today. One tragic aspect of the current disaster in Japan has been the plight of so many older people in one of the most advanced and wealthy societies in the world. Seniors are vulnerable members of our society. They deserve to be treated with dignity and the highest level of care that we can provide. As a society, we will be judged by how well we care for them. Everyone in this room wants a better system. Let's collectively start to build it today. Thank you.
And thank you very much, Pat. Okay, so what we're going to do now is we're going to hear from two fine gentlemen who are each going to give a perspective on strategies to improve seniors' care. First, we're going to hear from the acute care setting perspective. That's Dr. Roger Butler. And then we're going to hear from the community and non-acute care setting perspective, and that will be Dr. Meryl Hasnain. I'll introduce Dr. Butler first. Roger is an associate professor of family medicine at Memorial University and chair of MUN's Family Medicine Geriatric Rotation. He's fresh back from sabbatical, where he was interested in geriatric triage and where he visited 3 large hospital sites in Australia. And so while there, that's what helped him to formulate a new approach for geriatric care in our acute care hospitals based on the Australian model of geriatric care. So Roger's going to walk us through that and give us his thoughts, and then we're going to hear from Dr. Hasnain. So over to you, Roger.
Thank
Let's give him a round of applause.
Thank you, Jane, and I'll just walk you through the slides as they appear. Thank you for the privilege of being here today. When we look at people who enter the emergency department, I got frustrated because I see my patients every day going into emerge, and the system is so complex now, and everybody has good intentions, but the system seems to be designed very, very well for one problem. And with elderly people, it's never one problem. It's always a combination of problems. Sort of the initial presenting issue, which is often a fall, or could be confusion, it could be urinary incontinence, it could be a family in distress. But that's usually the combination of a dozen different problems. So if we got a factory that's designed to look at the head, and look at the heart, and look at the back, we need a factory that's designed to look at the whole person. And you're seeing these designs start to evolve. So in 2007, I met a Dr. Kaplan from Australia who talked about doing a good deed. And he did this talk on discharge early from the emergency department. And in Australia, he had put together a way of navigating through the hospital system and improving seniors' care. It's an interesting statistic that the Australians talk about. When acute care hospitals shut down during periods of strike, mortality rates for seniors decrease. You would say, well, how could that be? And then you've got to say, well, maybe the factories are not working as efficiently as they should be working. So we need to redesign the factory, which I'm talking about the acute care factory, the hospital, to meet the needs of our seniors, okay? Not the needs of the hospital. So let's take it away, and I'll start on, and I'm going to take you on a journey of a 70-year-old through a hospital. And this is a complex journey, but I'm going to try to show you some pivotal points that if you change the way you do the business, you can tremendously improve seniors' care. So let's start off with slide number 1.
You're going to press the buttons yourself.
Okay, so I can do that.
The green one is forward, red is back, and there's a pointer for you.
Okay, great stuff, Pat. Thank you. Okay, sorry, gotta go back. Okay. This is a philosophical slide. Time to care is increased disability. Time to care is increased length of stay in acute care. Acute geriatric assessment units decrease acute geriatric mortality by 20%. Now, how can I say that? Well, if you look at European data, in the first 30 days in hospitals, you can drop your mortality rate significantly if you take a geriatric approach. Geriatric focus is essential. The very old and the very young have fragile reserve capacity, so time to treatment is essential. And this is the premise. This is a basic functional, attitudinal change that has to be made.